dialogue. It's obviously a two-way conversation that we will have. We have a group of very eminent speakers today, and I call them eminent because they are in the field of practicing the control of AMR in the community. We have also invited all of you to this conversation, to this dialogue, given your involvement and engagement in the field of AMR control and other public health activities. We would also like you to ask questions. The way that we have designed it is that we have identified a few speakers who will be asking questions after each of the sessions. And at the end, we will have an open forum for questions to be asked by each one of you and who would like to have this conversation. So the objective of today's dialogue is, and I've shared the agenda on the chat box, is first of all to experience with smart diagnostics. And when we talk about smart diagnostics, it is about safe, mobile diagnosis that is affordable for all, diagnosis that is rapid and that is reliable, and also a transparent diagnostic, a diagnostic that is also transferable across various kinds of health systems in the low and middle income countries, and how we would like to adopt them in the public and private sector. We know that the Indian Council of Medical Research, and we are very happy that Dr. Kamini Walia, who leads the AMR effort at the ICMR, and in fact leads much of the AMR control work in India with various partners, is with us today. We know that ICMR has regularly now published the various kinds of essential diagnostics list for the country, and that has been very widely accepted by the public health and various kinds of practitioners in India. So we'll hear a lot about that. We will hear about the application of digital platforms and technologies for sharing knowledge across the various sectors. And we are very happy that IIT Delhi, where the government of India is setting up the artificial intelligence and the digital health hub in India, is also a party and one of the co-kind of sponsors of this conversation and dialogue. We will talk about improving the use of data, and we will hear from various practitioners who are using the data, who are generating the data, who are utilizing that data in their day-to-day practice. We are very happy that Indian Academy of Pediatricians is represented by Dr. Chaudhary here, and various other partners, including I see Dr. Rajiv Tandon also in the audience list. We would be very keen to hear from both of you. And finally, also the enabling of antimicrobial stewardship at the individual, family, and community level. We have IIT Kharagpur, which is working at the community level, and Dr. Lahiri is representing IIT Kharagpur today. And hear from him about the work that is happening at the community level. I'm sure that many of you who are in the audience are also working very closely with the community. In the community, we will also hear from Dr. Rajeshri Das about PCI's work at the community level, particularly with the women's leadership, and looking forward to hear all of that. So with that, we will start the conversation. I know that some of you have other engagements and will have to leave. So I will start by requesting Dr. Indrajit Chaudhary to outlay the objectives and outline of the AMR dialogue that we are having today. Over to you, Indrajit.
Thank you, Rajda. Vinay, Tejbir, any of you will put the presentation, or should I?
No. I think we are ready with the presentation. Tejbir?
I'll do that. Just give me a second. I'm presenting this.
Oh,
Yeah.
Thanks, Kaushik. Yeah. So first of all, I'd like to welcome all of you in the dialogue, in this dialogue. This is not just one dialogue. I'm so happy to say that we are actually unveiling a series of dialogue on antimicrobial resistance and trying to build a unified front against silent pandemic. And I'll go to what we are trying to do over here in next few slides. Kaushik, please. Yeah, so today's dialogue is a first webinar. Here we'll be talking about smart diagnosis for AMR control in India. Smart, as Rajda already said, this is safe, mobile, affordable, reliable, rapid, and translational. So we'll be exploring AMR control with sophisticated smart diagnosis. So just to look into the AMR crisis and that it really requires urgent attention primarily because of these four reasons we can see very clearly. One, of course, is eroding health outcomes and rising mortality. So routine infections are now causing deadly outcomes, even deaths. Threat to modern medical procedures, including surgery, chemotherapy, childbirth safety is being compromised. Skyrocketing economic cost of from AMR, the longer illness and expensive treatment is a burden to the economy, not just in individual economy, also for the overall GDP. And cost of inaction exceeds the intervention expenses. So whatever we are required to do the intervention is much lesser cost probably than the cost that we are incurring because of inaction. So, and delaying the response will worsen the impact both on the health and on the economic side. So it is really urgent to start doing something on that. Kaushik. Yeah. So here we're trying to talk about that we need to probably build a ecosystem because there are multiple players there, and here most of the people who are invited here Gentry, they're all working in some or other ways on AMR from various different sides. But we failed after our quite some time. For quite some time, we are working on this issue and understood that probably it is important to build a collaborative platform and bring everybody together. So in this PCI and QEI initiative, QEI is an initiative of IIT Delhi. So PCI and QEI has come together. PCI is a non-profit organization. So just give me I'll take a few moment to talk about ourselves. So what we try to do, we take science to the field. So that's the one important work that we do. And we try to build the ecosystem by bringing all critical stakeholders and knowledge together, using design principles to arrive at individual win-win of different collaborators to fulfill their interest and solve for the gaps, because there are many times there are those gaps. So we solve for those gaps to build the ecosystem. And we drive scale by working in the confluence of government, market, community. We call it Samaj, Sarkar, and Bazaar. We work with all three of them to drive scale and scalable impact. So that's what PCI does on multiple different issues. So AMR is one issue. We felt that is very important for us to do that. We have been very fortunate to have QEI initiative with us, which is an initiative by IIT Delhi. Quality, equity, and inclusiveness is in public health is QEI's primary mandate. With IIT Delhi, of course, we have a entire credibility and convening ability of IIT Delhi to bring multiple stakeholders together. Academic rigor and technical excellence. We don't need to talk about IIT Delhi's academic rigor and technical excellence. Established network with all streams and sectors of knowledge, and very deep understanding on design, research, and management science, because this particular QEI initiative is held at the Faculty of Management Science in IIT Delhi. So we get the benefit of having a very deep understanding of design, research, and management science. So two of these partners, we have thought that it will be very important to bring multiple different stakeholders together. And if you see, both PCI and QER are non-partisan stakeholders. So we do not run hospitals, we do not run diagnostics. We are non-partisan stakeholders in the AMR domain. So that brings probably a little bit of unbiasedness and legitimacy for us to take forward this effort. Next. Yeah. So these are the objectives of today's webinar. So what would like to see in today's webinar? One is experience with smart diagnostics in India, adoption in public and private healthcare, knowledge gaps among the stakeholders, barriers to scale up within Indian health system. Second, we'll also look into application of digital platforms and technologies. And Bernard is here, we'll talk about that for sharing knowledge, integrating data and monitoring usage of data by stakeholders. Third, improving the use of data for decision on antimicrobial prescription by practitioners, understanding constraints, challenges, and opportunities, and enabling antimicrobial stewardship at individual, family, and community level. Of course, IIT Kharagpur and also Rajshri from PCI India will talk about that and how antimicrobial stewardship can be done through awareness and social mobilization. So these we all have experts here, but this is in my understanding. What are the current key barriers that we have understood for effective AMR control? And if we break that down into critical obstacles, these are 6 most critical obstacles that we find. One is fragmented data. So labs and hospitals are generally disconnected. Is limited awareness by the practitioners. Most practitioners don't have enough awareness, and we don't generally have trainings for them to on that. Time pressure, high patient load challenges, broad spectrum usage, which provide a quick fix of default antibiotics, siloed operation, disconnected clinical units, and data sharing gaps. There is no seamless integration of data, and a huge load of data is being gathered by hospitals, labs, and practitioners, but they are not integrated. So these are the 6 key barriers we felt for effective AMR control. Kaushik. Yeah, so if we look into AMR strategic focus and key areas to lead timely AMR response and action, these are the 5 things that we need. One, of course, the first one, we have a lot of discussion around that in today's webinar, is around diagnostics, rapid point of care tools, innovative diagnostics to enable timely and accurate AMR detection is one important strategy. Second, of course, is stewardship, effective antibiotic usage, implementing programs to ensure responsible and optimize antibiotic utilization. Third is awareness in community to clinic education. So build a widespread knowledge on AMR from public to healthcare providers. Early action for critical success. Delaying interventions increases risks. So leadership must act promptly. And leadership drives unified AMR efforts. Strong leadership fosters coordinated strategies against AMR challenges. So we require leadership drives for that. And we find a lot of traction within the government, and the government of India is quite focused about it and quite keen about it. We need to bring all of our acts together to do this. So the AMR pillar, so we thought that these are the 3 main pillar of AMR, and we have tried to make it AMR, which is like actionable strategies with smart diagnostics. A clear vision and measurable outcomes is required, like implementing smart diagnostics across public and private health system. That should be the first pillar. So actionable strategy around smart diagnostics. Second, and very importantly, is a meaningful investment in digital platforms. So that is quite important, that transform clinical microbiology to digital platforms and enabling real-time dashboards. That requires investment. So that investment is required, and so that we can create a continuous feedback loop for improved clinical decision making. And third is responsible stewardship focused on equity. So ensuring access for all communities and engaging and empowering individuals and families to initiate antimicrobial stewardship at the grassroots level and fostering collective responsibility. So these are the 3 major pillars that to approach the AMR resistance. So this is something that I love to talk about. So I'll talk a little bit about it and how we can mobilize community for AMR stewardship. While work has happened to some extent on the hospital side and diagnostic side, on the community side, the work has been very less. So how we can actually leverage trusted network to combat AMR, and India poses a huge possibility, specifically because of the extensive SHG network, which we could use for health and nutrition on multiple different other spaces. We believe that on the AMR space also it is possible. So India has 10 million self-help groups trusted for delivering health and nutrition and livelihoods program in the community. It's a strategic opportunity because leveraging these established groups provides unique platform to communicate antimicrobial resistance through relatable and culturally relevant narratives. And trusted community institutions SHGs are trusted community institutions. They are credible, they're grassroots institutions by women, and that can influence behavior and promote adherence to antimicrobial practices, which we have found in multiple different areas. And here I'll say a small story. I was in Begusarai in Bihar, and one Asha, when I was talking about all those antimicrobial resistance, because it's very difficult for to explain this technical terminologies to at the grassroots in the community. So the way she understood is that which was very interesting. So she said, of course in Hindi, but I mean translating, finishing on medicine is like finishing the work you started. It ensures the job is done right. So if you don't finish the medicine, that means the job is half done. So if we convert it that way, the message becomes much more relatable. So those are the areas we are like those are some ways we have found to do like the stewardship of the community by mobilizing them is possible, and will be important pillar and not to be left behind. So that's all from my side, and let's join hands for unified action to safeguard health and combat AMR today.
Thank you, Indrajit.
Welcome
Thank you
everybody.
for this introduction and laying out the objectives, and particularly about the ASHA quote. I think we will deliberate on that a little bit later. In fact, there is a question for you from CCDT, Dr. Sukanya Poddar, but we will come to the question later. We will now move to the next presentation from Dr. Kamini Walia. Thank you, Dr. Kamini, for joining this conversation. We know that you are outstation, but thank you for finding time. And we will just straight away move to you for your deliberation.
Thank you. Good evening, everyone. And thank you for inviting me to this very important discussion. At ICMR, as Dr. Ghosh mentioned, I have been leading the AMR Antimicrobial Resistance Initiative. And what we often face is that most of the time it is antibiotics first and diagnostics later. What we see is that there is extensive use of broad spectrum antimicrobials which are dispensed or prescribed without doing any diagnosis. Even when the doctor has diagnosis, the doctors don't like to de-escalate if the patient is getting better. So we need more of a diagnostics first approach compared to the empiric antibiotics first approach, which we have been seeing all these years. One of the major deterrent, I think, in terms of the uptake of diagnostics has been that the cost of diagnostics is more than the cost of antimicrobials. So high cost, limited access is actually one of the key deterrents because of which diagnostics, even when they are available, are not being utilized well in the low and the middle income country settings. So one of the key steps towards this from the government of India has been the free diagnostic service initiative, which is being implemented by National Health Mission. And in that, ICMR has devised National Essential Diagnostic List. which makes it mandatory that all the district hospitals must have culture facility, whether it is a manual culture facility or an automated culture facility. A culture facility must be made available along with the microbiologist at district hospital level. My team has undertaken a survey in 5 states across the country. And what we see is that there is a good amount of compliance to this guidance at the district hospital level. And many states have started procuring automated culture systems and started hiring microbiologists. So, this we see as one of the sparks that will lead us into improving the uptake of the existing diagnostics, and doctors relying on the diagnosis rather than prescribing empirically. Uh, but even in the situations where diagnostics are available, unless they are affordable, they are available readily, and they are the turnaround time is good, there is very little intent on the part of the doctor and on the patient to spend on these kind of diagnostics. So diagnostics, even when they are available, are often seen as ancillary and not integral to antimicrobial stewardship, which we define as rationalizing the use of antimicrobials. So, what we should be doing as a country growing forward, because the levels of antimicrobial resistance that we are seeing are increasing exponentially every year, and this is actually driven by excessive use of broad spectrum antimicrobials. Now, what we need is a paradigm shift. And how we can do that? I think the first is that we should be seeing diagnostics as a central pillar uh, to antimicrobial stewardship and to antibiotic prescriptions, so that every antibiotic prescription should ideally informed by diagnostic evidence. So, as I said, it should be diagnostics first approach instead of empiric antibiotics first approach. Um, Although in some critical situations like sepsis, rapid diagnostics can be combined with empiric therapy, where the doctors should also be willing to de-escalate following the available of lab results. Uh, Most of our diagnostics with relevance to AMR or the antimicrobials are mostly lab centric. Can we really move them from lab to point of care? And that will be one of the major paradigm shifts, which will reduce dependence on centralized labs, which are delaying the results. And that is actually happening in many settings in states as well, where the cultures are sent out and the reports are never seen or never given to the doctor. And one of the key developments which we are seeing, which is not a very positive development, is increasing resistance to typhoid in our country, which is completely driven by the empiric use of antibiotics. Also, we mostly see diagnostics as a cost burden in addition to the treatment, and it is not usually seen as a cost effective investment. And that's something that our microbiologist friends can really create more awareness about to the policymakers, to the payers. And also the government needs to create more mechanisms for reimbursement and incentivizing the use of advanced diagnostics. The last point I want to make is that so far our approach has been limited to the technology push. We imagine that if we have diagnostics, they will be used, but it doesn't really happen like that. One thing is that even for a malaria RDT, when it became available, it required tremendous amount of training, as well as convincing the policymakers to use that particular diagnostic. Although it was a very simple test which was to be conducted. Um, Antimicrobial resistance testing diagnostics. Uh, which are under development, which I see through my participation on various advisory boards or other other initiatives will not be that simple. So the innovative diagnostics would have to be coupled with the training infrastructure and integration into the clinical workflows, and this is going to require really a real good amount of hard work, and so that we are able to make these solutions scalable and context specific in the low resource settings. So these are some of my concerns, that even if when we have new diagnostics, it is not going to be a very easy path. And yet, I think discussions like these should continue to highlight the importance of diagnostics in AMR. For a long time, we were talking of antimicrobial stewardship, but we did not realize that antimicrobial stewardship will not stand on its own and would have to be supported by diagnostic stewardship. And that's where the role of diagnostics is paramount and very, very crucial. I will stop here. Thank you, Dr.
Thank
Ghosh,
you.
once again for this opportunity.
Thank you, Dr. Kamini. If you just have time for a quick question, then Dr. Rajiv Tandon would like to ask you a question, but we'll keep it
Thank you,
short here.
Thank you, Dr. Ghosh. And as always, Dr. Kamni, you're absolutely excellent. But just a thought that in today's environment where informal healthcare providers are actually really looking at the major chunk of irrational antibiotic use, do you also think there would be a need of prescription audits with informal private providers? And we have PCI here which can do that through host clients. Because unless we exactly know what's happening, uh, you could bring in different antibiotics, you could bring in different diagnostics, but AMR is not something we'd be able to handle well.
Yeah,
Your advice on that?
I completely agree with you that we need this kind of. First of all, informal healthcare providers should not be prescribing antibiotics at all. They are not trained to prescribe antibiotics. But at the same time, we need to take care of situations where there could be no doctor available. So that kind of a blanket ban is not something that our country is ready for at this time. So that's why I think more awareness around the downside of, or the side effects of irrational antibiotic prescribing and how it impacts the future longevity of these drugs is very, very important. I agree with you that these kind of surveys are definitely an eye opener, because the practices change. The practices vary from one state to another, from one setting to another, and this can bring to light the misuse of antimicrobials in community, and also will have a huge impact on diseases like typhoid or diarrheal diseases, which are becoming drug resistant.
Thank you.
Thank
Thank
you.
you. Thank you for that. Thank you for the question and also the reply. We will now move to the next presentation, but thank you, Dr. Kamini, for this very, kind of uh, scrutinizing conversation on this. We will put this in the paper that we develop after this, which will be our guiding paper to move forward. And those who have questions, please put it in the chat box. We will get back to Dr. Kamini with the questions and revert back to some of you. Thank you so much, Dr. Kamini. We will now move to the next presentation from Dr. Sonal Saxena, who is the head of the Department of Microbiology at Maulana Azad Medical College in New Delhi. She will speak about the role of early diagnosis and reporting for antimicrobial stewardship in India's tertiary healthcare. We know, Dr. Saxena, that you have another AMR session after this, but thank you so much for finding time for this. Over to you. Can you
Thank you,
see
Dr.
the
Ghosh.
slides? Yeah,
I hope
thank
I'm
you.
audible.
Yes, absolutely fine. Thank
So, yeah, I can see the slide. Sure. Thank you. So I'm going to talk about role of early diagnosis and reporting for antimicrobial stewardship, particularly in India's tertiary healthcare. As I'm working in a tertiary healthcare system at a hospital, and as Dr. Kamniwalia very rightly said, there is a distinct distinction between what we diagnose and what is prescribed in the hospital. Although We may be in the same building, but there are sometimes a lot of distances between what is prescribed and what is diagnosed. So next slide, please. So next slide, please.
Kaushik, next slide, please. Just give us some time. Sorry for that, Miss Kaushik.
Yeah, I'm.
Somebody else should then you can just move away, and
Just a
then
moment.
Tejbir can, yeah.
Is
Tejbir?
it now? Is it now
No, it is
visible?
not. No, no. Tejbir, can you do that? Tejbir is doing it, so Kaushik, just leave it.
Yeah, yeah, yeah.
We can't see that. There you go.
Yeah.
Thank you.
So taking rightly from Dr. Walia, WHO has defined diagnostic stewardship as the coordinated guidance and interventions, which actually provide a microbiological diagnosis to guide these decisions. And the purpose of these diagnostic stewardship is to promote an appropriate and very timely diagnostic strategy, which is going to form the basis for prescription of antibiotics. Now, what normally happens is that even though there is a diagnosis, it doesn't translate into an antibiotic prescriptions. And in a country like India, diagnosis usually relies on methodologies which are quite slow. So what we've observed at our center,
Visible now?
I think the slides are stuck again. We are back to slide 1.
Oh.
Yeah.
Oh,
So
just
what we are
one
stuck
person
on
share.
are the slower culture method. Majority of even when they are in a tertiary care setup or in an urban area, do not have automated culture systems, do not have identification systems, and being diagnosed and what is it to the clinician on a clinical report. So the faster you diagnose, the lower is the targeted therapy utilization of the antibiotic as a targeted therapy becomes higher, and you lower down the misuse or the empirical antimicrobials. So an early detection, according to one study, could prevent up to 20% of hospitalizations. So the takeaway remains that there are rapid, accurate diagnostics. A lot of these would depend on, in my next slide, I'll be talking about that, would depend on the rapid diagnostic techniques, molecular methods, and also on rapid culture diagnostic technique. Next slide, please. Yeah, next slide.
I've changed it. Do you want me to change this one as well? Importance of early diagnosis?
So I'm going to, I'm just seeing now. So this is just one example that a patient who presents with fever, cough, and the clinician suspects that it is a community-acquired pneumonia and sends a rapid multiplex PCR panel. Now, this is a very, very ideal system where I would expect that there is a viral etiology and the antibiotics are not initiated. In another case, the patient who would have received an empirical antibiotic therapy is de-escalated because there is a respiratory panel which says that it is actually a virus and not a bacteria. Then similarly, if there is a sore throat, we believe if there is a POCT, a point of care test, which tells you that it is a bacterial sore throat, because 80 to 90% of the sore throats are actually viral, and one of the major causes of outpatient antimicrobial therapy. So this is one condition where it can, you can stop the therapy if you have a rapid or a point of care test telling you that if it is strep negative, it does not require an antimicrobial therapy. The other thing is that recently the IDSA guideline, the Infectious Disease Society of America, very clearly said that even if you suspect a viral pneumonia, try not to give antibiotics. They are not recommended unless and until the patient is immunosuppressed and you believe that it is an hospital-acquired pneumonia. Otherwise, prophylactic antibiotics should not be given. Now, if there is a if there is an unusual bug. Like you can see in the report, this is from our own lab for primary concern. We blotted out the patient identifiers, but it tells you that there is a bug which is there, and this requires a lot of infection control measures. Now, in such a situation, your rapid diagnostic techniques are going to alert your ICU, and the IPC implements procedures will be implemented. The infection prevention and control measures will be implemented very soon. Next slide, please. So if you have a culture system and your rapid identification system, you can actually give a targeted therapy, reduce empirical prescribing, and believe in timely intervention. Now, when we look at the WHO AWARE classification, the access, watch, and reserve, majority of the antibiotics that we've seen in the recent years, especially from tertiary care hospitals, are already resistant to the access group. So what do we go in this? We use more of watch group and we use more of reserve group. And as a result, the resistance to these antimicrobials is also increasing very, very fast. Next slide, please. So what are the methods which are available to us for a faster diagnosis? This is from our own thesis, which we did last year with one of our students, where we compared the results on a turnaround time using a rapid system called MALDI-TOF. Now, the system itself costs more than a CR, but the average turnaround time, just look at it. Instead of having a susceptibility testing report, we saved almost 30 hours. That means a day. Here, we were able to give this report within, say, 24 hours and 10 hours plus on an average for gram-negative organisms, and for a gram-positive organisms, we were able to give the results in 40 hours. Whereas in conventional antimicrobial therapy, this would have taken it such a high time. Similarly, for all the other organisms, like we were talking about Salmonella species resistance, we were able to save these. And this brings down to targeted therapy. As soon as you release this report, it brings the clinician switches to a targeted therapy, and that results in a drastic underutilization of antibiotics, which are in the reserve category. So all these reduction of time were actually significant, and this was not yet published. It is part of a dissertation which was done by my student, Dr. Vimal, under me and a co-supervisor of Dr. Bhanu, who really worked very hard on this, bringing down this turnaround time. Next slide, please. So although the investment was of a very high nature of more than 1 crore, but if we demonstrate this every day into our practice, it becomes very, very simple. To say the amount of money that will be saved from the access of antibiotics will be recovered in very short time as an investment from this. So using certain rapid molecular tests. Now, again, the molecular tests usually burden the laboratories with a very high amount. They are very expensive. But if there is an additional direct communication that, see, this is viral and please, scale down your antibiotics or remove your antibiotic coverage, it really helps. Rapid certain phenotypic tests, which I've just mentioned, like MALDI, but the issue here is that they should be with additional communication. If they are without an additional communication or only via routine communication, then it's not going to save much time or money for people. Next slide, please. So whenever we have a rapid or a smart technology, we should build it up in such a manner that we are able to communicate. But then what are the challenges in our settings? One of the biggest challenges is resource constraints. There are lack of state-of-art laboratories. It takes huge amount of effort to purchase something and to maintain that equipment in the laboratory, the consumables, the AMCs, the adequate IT systems. Majority, in fact, more than 90% of the government setups do not have an electronic record systems or an electronic lab report systems, what we call as the lab management systems or information systems. And this results in a delay of these reports to the clinician. The second part is high patient load. Come to our OPD one day and you will realize there are 2,500 patients standing in front of one OPD. Now, those many samples, those many reportings. Then there are training gaps. Now, as the Secretary of Indian Association of Medical Microbiologists, I've tried to address this training gap by introducing 2 online courses. One is still going on, and that is what Dr. Ghosh was talking about. I have a lecture there at 6 o'clock. Then we have an online course on antimicrobial stewardship, which is the first cohort is running from 4th August to September. And we also initiated a certificate course in infection prevention and control, where we took nurses, medical officers, practitioners, apart from microbiologists, and trained them in IPC. We've already completed 2 cohorts, one last year and one this year. And we've seen a lot of changes, because it's a kind of a training of trainers, where we train them and then they go back and train their own people. The other most important aspect, which I feel, last but not the least, is your lack of insight and administrative support. Very often, people believe that the labs, what is the need to strengthen the lab, and so on and so forth. Next slide, please. So here, the challenge is not only in capacity building, but also in maintaining that capacity. The other aspect, which I always is a cornerstone of antimicrobial stewardship, is an AMR surveillance, because unless you know what's happening, you cannot do much change. And globally, this problem is addressed by GLASS, the Global Antimicrobial Resistance and Use Surveillance Systems. And it actually defines the response, and it tells you how big the problem is. So can we go to the next slide? So this surveillance nowadays, the surveillance is also done using environmental genomics, and it has become a One Health approach, where machine learning, AMR genes, so many things are happening. So there is early detection of emerging resistance, and then in giving you a kind of a stewardship programs that, okay, this is what my status is, and I should not be using this particular drug, and also for public health response. Next slide, please. These factors keeping us in mind as a capacity builder, we decided to create a network for antimicrobial surveillance. Now, this runs from a healthcare provider, the specimen, the ID testing, the results, and then goes into the surveillance network. And we're utilizing this data to form regional national policies. Next slide, please. So what we did in Delhi was to create a network, which we call as the Delhi Network for Surveillance of Antimicrobial Resistance. Next slide, please. That is DENSAR. So we call it a DENSAR, where we triangulate data from 24 laboratories. It is a complicated procedure, and it required a lot of manual data cleaning. It still does. There are inconsistent data fields. There are antibiotics, organisms. We did a lot of capacity building. I should be showing you some photographs of that. And we did a lot of training and experience in data entry, management, analysis, interpretation, and codation. Next slide, please. So what we did in this DENSAR was that in 2019, we made this, and we are very thankful to WHO for supporting us initially with a lot of hand-holding, with a lot of support in terms of helping us to organize the various training programs. Even in the COVID time, we held a lot of software training programs on WHONET. Personally, I have conducted more than 25 WHONET training workshops to collect, collate, and analyze this surveillance data. And we also did a lot of wet lab trainings in order to build the capacity of our labs so that we get a quality assured data. Next slide, please. Now, since then, we've moved 5 years ahead. We've had a lot of meetings. We've had a lot of discussions on this. Next slide, please. And this in last year, in 2023, next slide, please. In 2023, this was adopted by our NCDC from WHO. So for the past 2 years, we've been, next slide, please. We've been submitting our surveillance data from these 24 laboratories to NCDC for submission into GLASS. And we also published this article in the Journal of Medical Microbiology, where we published the findings from this as to what were the challenges and what were the output that we got from the first year. Now we are ready with another 2 publications, which we are in the process of finalizing the manuscripts and submitting to journals, where we submit we are submitting the data from the last 5 years. Next slide, please. And we've had a lot of challenges from these laboratories. There are procurement challenges, particularly in the government setup, with the lowest quote and and the gem coming into picture. So this leads to an erratic supply of consumables. Sometimes we have the disc, sometimes we don't have the disc. The standard guidelines. So whatever training we did, capacity building that we did, we made sure that everybody follows the same guidelines. Lack of automated systems, as I have already shown you how the turnaround time can decrease. But many of the laboratories that we have in our setup still do not have. 6 laboratories which are there in the government setup do not have any of the automated systems. Then there is a constant change of manpower. Sometimes the technician will leave, he will be posted in some other unit, and all these factors affect the data quality. Then something what we call as the colonization versus pathogen, where we cannot distinguish because we don't actually have the software systems where we can go into the patient history and analyze as to how whether this is actually a pathogen or is it actually just a colonizer from that site. And then computer software unit, all these we identified and we had published this in our paper in IJMM. Next slide, please. So still we are moving ahead. We have lot of data which we've generated over the past 5 years, and we've realized that there has been a constant increase in certain phenotypes. The colistin resistance is increasing. Salmonella typhi, slowly we are seeing resistance even to the last prescribed drugs like ceftriaxone. Next slide, please. On the other hand, we have seen that there is a reduction in, say, Salmonella MDR and other things. Now, this is just an evidence to show you that one of the hospitals, like the Amrita Hospital, they showed that the appropriate therapy improved when they restricted antibiotics, and mean monthly antimicrobial cost dropped down by 14%. And another initiative, which was the ICMR's initiative, initiated by Dr. Walia, they had a lot of AMS committee formation, antibiogram-based policies, and there they audited various prescriptions and tracked the idea, and they found a lot of improvement in antimicrobial prescriptions. Next slide, please. So, although we say that the tertiary care centers have a lot of issues, but I always feel that the structured AMS programs which leverage these early diagnostics and real-time data, they yield a more rational antimicrobial use. The cost efficiency and then adherence to these practices, because at the end of the day, even the goal of a clinician is to improve the patient's health and send them home as soon as possible. Next slide. I think we're at the end. Yeah, so just to summarize, the early diagnosis and reporting matter, especially in a tertiary context, because it allows them to narrow down the antibiotic, de-escalate the antibiotics. Of course, over a time, it may not be very rapid, but over years, it is going to bring down the resistance as well. And it optimizes our resource. We all say we are hard pressed, we have a lot of resource crunch, but unless we are in an organized manner, this resource crunch will not go. We are wasting too much of money on antimicrobials rather than putting it for diagnostics and for the IT-based initiatives, which can, rapidly transfer our reports to in a real-time manner to the clinicians so as to improve the outcomes and otherwise increase the safety. Next slide. I think with that we'll end. Yeah. Next slide. I've already mentioned that. So thank you so much. I still believe that if you can't measure it, you can't improve it. Unless somebody tells me this is wrong with you, I will never correct it. Thank you so much.
Wonderful. That was wonderful, Dr. Saxena. Thank you so much for this overview and actual actions which are happening at your hospital. So we have a question for you, and I have requested my ex-colleague, Dr. Somendra Bagchi, to ask you that question. Dr. Bagchi has many years of experience of working in the community delivering public health goods. And if you are ready, Dr. Bagchi, will you please ask the question? Dr. Shomen Bagchi?
Can you hear me?
Yes, we
Hello?
can hear you. Yes, we
Yeah.
can hear you.
Yeah. Dr. Sonal, thank you very much. It is a very interesting presentation. My question is that it is a question of coordination. How a physician as well as with a microbiologist, they coordinate about the progress of the treatment. As a patient or as a patient party, I'm interested to know what is the progress of the treatment and how they can coordinate between. Over.
Yes, so that's what I said. One of our major problems is that we do not have real-time systems, which we can update. I believe there are many private hospitals which have initiated apps those apps actually tell you that the report is, you know, mentioned there directly and you can access it. So if you have certain biomarkers which are falling or certain biomarkers which are increasing, will tell you whether the infection is still proceeding in a patient or not. The other process is to do a follow-up culture. Now, many ICUs or critical care areas have a policy of follow-up culture where every third day they do a culture system, and that also helps the clinician in assessing the progress of their patient. But as I said, that real-time communication is the key here, which can be utilized by the IT systems.
Absolutely. Yeah. Thank you. Thank you, Dr. Bakchi, for that question, and Dr. Sonal for the answer. In fact, this is an area where probably Indrajit and Professor Dheer and others who are here, we can work together to see if we can address some of the issues in the gap.
Yes, definitely.
Thank you. Thank you.
Thank you.
So we'll move to the next presentation, and I have the pleasure of inviting Dr. Nikhil Fatke to talk about examples of diagnostics in AMR control globally. Dr. Nikhil will introduce himself and the farm, but also before Dr. Nikhil starts, I would like to say that after the presentation, I'll be requesting two questions, one from Dr. Saurabh Sharma and one from Dr. Pipasha Biswas. Nikhil, over to you.
Thank you so much, Dr. Ghosh, for calling me in, inviting me, and to the previous two speakers who've really simplified how I go about this. Lots of great insights. Can you full screen it, and I can go ahead and speak to it, please?
Kaushik or whoever is presenting, can you make this full screen?
Or otherwise, I can present it from my computer. That's fine also.
Yes. Or else, yeah, Nikhil, if you prefer that way, then I think
I can do it quicker from my computer. Then I don't have to keep saying next screen.
Exactly. So why don't you just move away from this and then Nikhil can present. Perfect.
Okay. Can you see my screen now?
Perfect. Yes.
All right. Yeah. All right. This is, sorry, excuse me. Sorry, it's not moving, unfortunately.
We have kept some layover time for these technical glitches. Yeah, good.
Yeah, I don't know why it wasn't moving ahead, but okay, now it is. So hi, I'd like to introduce myself. I'm Nikhil, and I'm the founder of GenePath, which is a diagnostics company, a molecular and genomics diagnostics company. So we've had people from government organizations and academia speak before, and now it's industry time. And I'm going to talk a little bit about my experience in this field globally. But before I jump into that, with just a little context of why Dr. Ghosh thought we would be appropriate to present. And this was made by me and my colleague Soni, who's also on this call. So thanks to her for helping with putting this together. All right. So we are a molecular diagnostics and genomics testing company, and we focus on infectious diseases, oncology, and inherited genetic disorders. I'm just going to be really quick about it. We're kind of interesting because we have three parts to our business. We have a clinical molecular diagnostics lab and NABL lab in Pune, but we manufacture kits and custom manufactured reagents and sell them in 9 countries globally. And we're also building platforms, so sort of like the Cepheid, GeneXpert, and BioFire, next generation of those, which are going to be lower cost. So there's 3 parts to our business. And I'll just give you kind of a glance. As I said, we only work in molecular diagnostics and genomic testing. We have an NABL lab in Pune. We have done now over 200,000 samples. This is a slightly older slide. And we make custom manufactured kits and reagents globally. So in the United States, we make these large multiplex PCR panels for CLIA labs, and AMR is a big part of that. We run a national newborn screening program in Turkey, which allows us to do things at scale. So every single baby born in Turkey, they are tested for SMA by our kit. We have a lot of CDSCO and CIVD are approved, CIVD approved tests in Europe and India, including oncology, infectious diseases, etc. We have a very special focus on TB and HPV diagnostics across all three of our verticals. And we are connected with the One Health approach. So in India, a lot of the government organizations use our kits and products for national wastewater and environmental surveillance, including now AMR from some of these GAMRIF supported projects. And then, as I said, we're building platforms to be kind of lower cost alternatives to the Cepheid Gene Expert system and the BioFire system. And by way of a segue from that is that the history of our company, my previous company was called HandyLab, and we built a product which went on to become the BD Max system. So Becton Dickinson bought that from us, and it became the BD Max system. So we have experience building these samples to result molecular diagnostic systems at kind of a global scale. Here's an example of a kind of a product that we would custom make for a client in the United States. So this is an example of a UTI panel, which has 5 tubes of various UTI targets, 3 tubes of a whole bunch of AMRs, and then 2 more tubes of STIs. And the client might use them in different combinations. Some might run them all together, some might run them in reflex manner, so on and so forth. And we build this for different CLIA labs in different insurance systems according to their reimbursement requirements. And we'll get that to in a minute. So this just gave you a very quick 3-minute background of who we are and why we have some sort of opinion in this space. But I'm going to talk about our experience either firsthand or through our partnerships in various countries. So we start with the UK. And in the UK, everything has got a very, very strong national and regional guideline dictated policy, so to speak. The NHS is very tightly involved, and everything is dictated by either the government or professional societies and hospital policies that are strongly enforced. There's a lot of antibiotic stewardship. There's a focus on cost effectiveness at the population scale. What's important is that they have well-defined and frequently updated protocols that work more often than not, and very robust systems with strong vigilance. Deviations are permitted with justification, and they have special approaches for subgroups like travelers, immigrants, etc. But most of the clinicians that I spoke to said they were broadly very happy with the system and how it works. So, if we have something to work towards or aim for, I guess the UK system is a system that kind of works better than many others. And as the previous speaker said, if you have something measurable, similarly, if you have something to work towards, then that makes your life a little easier. We have in the UK very tight coordination between the treating physician, the ID specialist, the microbiologist, and the pharmacy. And in India, medicine seems to be practiced more like individual superstars, and nobody wants to talk to anybody. And that really has to change. There are different protocols for OPD settings and ICU or hospital settings. The OPD settings do have more reliance on empirical or guideline-based selections. So not just empirical, but some guideline-based selection until test results are available, while hospital ICUs have more diagnostics guided. So they wait for the results before acting. But depending on the clinical situation, testing may be started in parallel with treatment. Blood culture, urine culture, phenotypic ASTs, molecular AMR testing, syndromic panels are all available and paid for by National Health. They may start with a broad spectrum antibiotic in an OPD setting, but they will quickly act on the results from any diagnostic test and de-escalate or rarely escalate as needed. And that de-escalation is very, very important, as was previously pointed out. That almost never happens in India. We need to take this into account and de-escalate. And from my talkings with specialists in the UK, they said while they're largely happy, everybody has a wish list and they want more rapid identification of pathogens in near patient settings. And the idea of the pathogen is their first priority, and then the rapid antimicrobial resistance or sensitivity detection following that. So, and Dr. Gauri Godbole and Dr. Suraj Sardesai were very helpful. I talked to a whole bunch of people, but these two were the ones that gave me the most amount of useful information. Then jumping across to the US, and the US is where not only we have a lot of connections, but we also operate ourselves. And in the US, it's a very heterogeneous system. There's a lot of variations between states, hospital systems, and insurance providers. And most of the decision-making process is guided by insurance. There's a clear bifurcation in protocols followed between OPD settings and hospital emergency or ICU settings. And in the hospital settings, more than 70, maybe 80% of decisions are based on lab testing. The pathogen ID goes first, and then resistance, susceptibility, especially if they don't respond. In physician clinics or OB-GYNs, pediatricians, etc., they often use prophylactic antimicrobial therapy if it matches their experience and what they think the pattern is going to work. But they are conscious to side effects. They generally know their patients and history because they have extensive AMR records. And if they can't determine, they will most likely order a big panel before pursuing. So if they're not able to make a good judgment, then they will wait for diagnostics. Their pain points and wish lists are that labs are primarily driven by insurance reimbursement and not necessarily clinical needs. Large panels are often used when diagnosis is uncertain, and that's not always very cost effective. And reimbursement policies can at times prevent labs from aligning with the best clinic interests of the patient or the clinician. So that's a little bit of a side effect. They always want more low-cost, rapid turnaround time diagnostics, but they're very clear to point out that they don't necessarily want bigger and wider panels with unrequested targets because they will likely not be reimbursed. So every time we make a panel for a client, we only include what they want and what will get reimbursed. We never add even a single additional target because that will not get reimbursed. The challenge with that is it's really hard to create one glove to fit everyone in that scenario. So we have to keep custom building stuff for every lab system. In Turkey, diagnostics, all kinds, cultures, molecular testing, syndromic panels are widely available and are used extensively. Most, if not all, are paid for by the government. They have guidelines from professional societies. Deviations are not permitted generally. AST testing results are available pretty quickly in 12 to 18 hours, and results are acted upon immediately. They are very tightly linked to antibiotic stewardship programs, but there is a feeling amongst all the doctors that I spoke with that there's an over-reliance on diagnostics and a limited freedom to operate using clinical judgment or to improvise. Their main pain points and wish lists are better access to rapid diagnostic tests because cultures are often late and negative and viral diagnostics are challenging, and they want wider access to cheaper syndromic testing and more freedom to deviate from the tight policies if clinically justified. So that's the Turkey situation. And now to India, which is obviously our focus. Almost all, as both previous speakers have said, almost all antimicrobial treatment is empirical and not etiological, regardless of whether it's in an OPD or hospital setting. From a primary care or first contact perspective, 90% of cases respond to what they give at the first shot. And so there's a limited interest in changing at that level. Often the first point of contact may be a non-traditional doctor who would prescribe broad spectrum antibiotics. Only unresponsive cases are escalated to ID specialists. And there is no concept of de-escalation. This is a huge component. There's a very strong reluctance from patients to undergo testing. Costs and delay in getting results, wish to get better quickly and not miss work, and self-medication is quite common. Even in hospital ICU settings, diagnostics are rarely used to drive therapy. They might do it in parallel, but it's just sort of a by-the-by kind of thing. And there's an extreme overuse of inappropriate or incorrect antibiotics. There have been some positive changes recently. And again, I'm talking talking to private doctors on the ground everywhere. I'm not talking about a countrywide intent. I'm just saying what's happening on the ground. There has been some positive changes, mainly in the case of insurance-driven payments in urban areas, where diagnostics are being now mandated by the insurance providers to justify payments. This results in a loss to the pharmacy, but it results in faster settlement of claims. So the hospitals have an upside to it also. And recently, the NABH has had certain requirements for antimicrobial stewardship. So these two work in tandem to increase compliance. So what are the main pain points in India? There's very limited access to diagnostics and poor turnaround times, often not the highest quality. Tests like cultures may not work at all because of pre-treatment by the patient themselves or somebody else before non-traditional healthcare systems. Conflict of interest to keep patients admitted for longer or beds occupied is a big problem. We have to remove OTC access to antibiotics. Diagnostics being significantly more expensive than therapy, combined with easy access, is a huge impediment to antimicrobial stewardship. Control on which drugs can be used by which group of physicians or clinicians in a setting-dependent manner. So everybody should not be allowed to use the highest, broadest spectrum antibiotic. And we need access to significantly cheaper syndromic diagnostic tests in clinically relevant times. And even if people see more and more biofires and Cepheids on the market, by the time the end user gets the result, it might still be 24 hours or 2 days. So we need to make them cheaper and more accessible. And even within the syndromic panels, the AMRs need to give us the subtype of the AMR, because that will help our clinician quickly zero in on what they need to do. Similarly, we need to have things like pan-bacterial, pan-fungal detection, large common viruses, so that you don't unnecessarily give the wrong group of antimicrobial. And then finally, we need access to newer drugs, which are available in countries like the UK and the US. I wanted to give you an example of the need for localized content. So here's a pneumonia patient from a local ICU, bronchoalveolar lavage sample. We tested it, this is a couple of weeks ago in our lab in Pune, and it got a whole bunch of bacteria as well as a whole bunch of antimicrobial resistance. This report is given to the clinician about 4 hours, and based on the pathogens and AMRs, a certain course of action is triggered. We have our own real-time PCR assays and targeted NGS that we're doing. And by doing that, we confirmed all these targets in the sample. But we also semi-quantitatively identified a slew of additional ones. Okay, and this semi-quantitative is important because you have to distinguish between colonizers and actual infectious causing agents. And so we saw this Ephesium, CMV, blah, blah, Stenotrophomonas, etc., and other antimicrobial resistance. And those actually have consequences on how the treatment would have been. So if the doctor had this information at the time of the initial biofire being submitted, they might have treated the patient differently. And we did give these results 3 days later, but it would have been good to have it in the beginning. And so the importance is to have localized content so we can't just import stuff from the West and use it blindly. So here's a little bit of summary. There are different realities and problems in different geographies, and it's really hard to have one glove to fit them all. That said, the UK has a good system that its clinicians are very happy with, and it would be good to analyze and learn from their systems. There is a clear need for rapid diagnostic tests and syndromic panels, pathogens and AMRs globally. However, over-reliance on diagnostics is also not the right answer per the Turkish example. There has to be the right blend of diagnostics and clinical experience or acumen, along with strong national and regional guidelines that are frequently updated. There has to be a separate diagnostic approach from OPD settings versus hospital settings, which have to be geographically appropriate and, as I said before, monitored and updated. So in the OPD settings, it would be good to have a simple to use, ideally an instrument-free, almost like a pregnancy test or a COVID test, a rapid diagnostic test for use in near patient settings that can identify the most common pathogens and the most common resistance targets. And in a hospital setting, it should be something far more comprehensive, sort of like what I showed in the previous slides within medium to high throughput. And that can identify a much larger pool of known and unexpected pathogens and resistant markers. So we have to develop separately for these two settings. And for India, to remove impediments to AMR control, we have to have enforceable national and regional policies. So more of what NABH is trying to do, strong antibiotic stewardship programs, definite removal of OTC access to antibiotics, primary physician education and access control of which antibiotics they can use. And the most important thing is a centralized payer system, because ultimately, if the same entity is paying for the hospitalization of the patients, the diagnostics and the antimicrobials, and they see it in the big picture, they will realize that they're saving money. And this is always works. If a patient is doing it out of pocket, they are only concerned about what's going to happen the next day. But when a system is paying for it, they realize that over time they are saving money through a variety of things. And that's the only reason why these national screening programs, whether it's newborn screening programs, HPV screening programs, whatever, when you do it at scale and the payer is the same for all parts of the journey of the patient, it makes sense financially. And there's no more powerful motivator than a financial one. So that's where I stop. Thank you. I'm happy to take questions.
So I think can I share my screen? I think I will share my screen and control that. If somebody can authorize me to allow me to share my screen. I think the host may have to allow me to share. Yeah.
Can you allow Bernard to present the screen, please?
Yes, got it. Got it. Can you see my screen? Can you?
Yes.
Wonderful. I think that's a good start for a presentation because we can talk about challenges which we face. So I think my presentation is going to be focused on how we address AMR challenges in India, and I think which is why I said that the situation, the technology glitch was a good thing for us to make this point. Now, our previous speakers have spoken about the challenges. People have spoken about a diagnostic first approach. People have spoken about the issues that we have. So I don't want to spend too much time on this, but I have the text on the slide. But I think most of the things that I have, the previous speakers have already spoken. Either it's technology, which is not there, integration. But I think I would like to add one more element, and which is there's not enough testing that's happening for whatever the reason is. And there are many issues and many challenges as we see it. Now, I would like to more present how we think we can address this challenge. And in my a couple of slides that I would have, I would more talk about how do we in India address this challenge. And is there a solution which can still be a solution with the issues that we have, with the challenges that we have right in the country? So to give you a sense, we look at this problem at three different levels. Right, one is at the local healthcare facility, then at the state level, and then at the national level. So these are three different issues, three different challenges related to each other in some manner. So let's say we look at the local healthcare facility. The issue is we do not have enough number of microbiologists, right? So we say, and hence there's no testing capability. Or in remote places, we just can't put a microbiologist because the number of tests that we generate is few. We are a very large country, and we cannot consolidate some of these things. So our challenges are really this: can we define return of investment for putting in equipment? And that becomes a chicken egg situation. Or if we have equipment, do we have people? Do we have enough tests? Can we do enough tests? And that drives how we deal with testing. And we believe digital technology, at least to some extent, can help with that. And I'm going to present that. The second would be, if you don't have that kind of data, then how do we basically look at, regional antibiograms? How do policymakers take decisions? How can we make things work together in a certain manner? For example, we've done a couple of projects, and the maximum we touched was 100 hospitals. We've done almost close to about 500,000 positive cultures over a period in time. But we realized that that is still a very small number compared to what our country is. So when you look at, but these are large number of hospitals. When I talk about 80 to 100 hospitals, that's a large number. Without technology, it is just not possible for us to deal with things. So that's the kind of thing I like to stress on. How do we use technology effectively to address this challenge? And now, even when I said 100, we started with 100 hospitals where we said we'll do a study program. GenePath was a nodal agency, and we were able to do 100 because we use technology. And obviously, other things we'll talk about as we go along. So these are challenges, and we believe that digitization of things should help in all the three levels. And we'll see how how that can be addressed. So I want to go back to a very basic process. I'm sure all of us understand this, but we're looking at the problem this way, right? There's testing that happens, and we all are talking about the same thing. There has to be more of this testing happening at lower cost, wherever it can be, in remote settings, in resource scarce settings. And how do we get this thing going? Because we don't produce those number of microbiologists to do the testing. So what do you do by which more of this testing can happen? And how can we empower people? How can we use resources in a certain way? Do we need a full microbiologist to help us achieve this? Is something that we need to discuss. We need to talk about, and we believe digitization can help. Secondly, when we look at if that happens in whatever sense, how do we look at interpretation? Now you need microbiologists to do interpretation. How do you ensure that the interpretation is of a certain quality? How do you apply all kind of rules? Through the exercises we have done, we've been able to apply hundreds of rules on a particular report, at least on a report, possibly 30, 40 rules, on an antibiogram, 100 plus rules. How do you do that manually? And we believe for interpretation, you need to have the ability to use digitization or technology. The third is in terms of reporting. How do you make sure that the reports that we produce, is it a simple antibiotic list that we produce and we actually put S.I.R. in a report and send it across to clinicians? Is that sufficient enough? What happens if there are more than one drug? Which one needs to choose from? How do we ensure that the person who's testing or reporting has a skill set to make that recommendation? And here again, we see the need for digitization and standardization so it can happen easier. Then when you have this data, and when a microbiologist is creating an antibiogram in a year, or once in a year, or twice in a year, there's a whole, like I said, we possibly do 120 odd rules that we apply on top of the antibiogram to make it more sensible, or make it more meaningful, right? Or make it more, well, we calling it purified antibiogram. Now, without digitization, it is not possible for us to achieve that. The next aspect is about how do we help a clinician with the right kind of prescription? How does he use, even for empirical therapy, an antibiogram, which is current, or in a particular setting? How does he use a stratified antibiogram? How does he know what should I, even in a hospital setting, how does he use a stratified antibiogram to make sure that his prescriptions are fine-tuned better? Or even in a OPD setting, how does he use it, and which antibiogram does he use? And digitization can significantly bring about change there. Lastly, it's about what stock do I, what is the stock that I need to have in my pharmacy, and how do I plan, and what do I plan, and what is it that I base that on? And unless and until I have an antibiogram and I understand what's happening on the ground, my stocking levels cannot be accurate. And we believe digitization here can also bring significant value. So we see, even in a low resource setting, low resource from a people, expertise, from inability to have expensive systems or use expensive diagnostic capability, or not have enough tests. These areas, if we digitize, we are able to bring significant value in the AMR management process. And we have attempted doing this. And each element of this, other than the stock access, we have fully digitized. And I think I'll share with you how that possibly works. Okay. Now, only when you do that, and if I say it becomes then the continuous improvement loop in AMR stewardship about testing, reporting, antibiograms, integration guidelines, enabling clinicians understand. Now, one of the other things that we've seen is one of the previous speakers, I think, spoke about how things work in the UK and how the ID physicians and the clinician and the microbiologists are fairly tightly integrated. And we also acknowledge that that integration does not exist in our country. Microbiologists do not interact with clinicians and provide the information that in a certain manner. So technology and digitization can possibly help doing that. And monitoring and feedback of what's happening and what's not working, and feedback in terms of feedback, so the entire loop and cycle can work better through digitization. And we believe that's where digitization can significantly help. Now I'm going to share with you a couple of things. So for example, when we said, when I go back to the process, that I'm going to possibly look at one or two or three of these processes and talk about how digitization would actually help. So when you look at the simple culture interpretation, so when you actually do the test, investigation, and then we are saying that if we can keep this as easy and simple, where whether it's an AST test or not, you basically, or even as an AC test, you basically look at somebody's entering either an MIC value, which can be picked up from the system directly if they have an equipment, or they enter the diameter, the zone diameter onto the system. And the system defines what the antibiotic policy is. This entry alone can help, report absolutely accurately. So for example, this screen gives an example about how just by entering the zone diameter, the system is able to compute after applying breakpoint rules. And it says this is S.M.A.R.R. It also has the ability to tell the person, the microbiologist, or the person who's, I'm going to interchange the word microbiologist and a person who's testing or a technician, and we believe this can be done by a technician. And if the technician just enters this information, and the system has the ability to alert and tell you that you need to do a retest because this has failed, or there's a flag which has been flagged off. So just as an example, some of the alerts could be, let's say there's a penicillin which shows S, as interpretation, and ampicillin is also there with R. There is a problem, and the system alert saying you need to do another test, or you need to do a retest, or you need to do another kind of a test. Now, and there are examples of whether a vancomycin resistant enterococcus or a clindamycin and erythromycin interference, and when the system has this intelligence to come and tell you that you need to do another test, and it alerts the person, the technician can take a decision. The technician can decide what to do, right? So bringing digitization can help even a technician to just put in the basic information, and you have a better quality, a higher quality interpretation, and hence reporting. Similarly, based on this information that is there, the system tells you that this is your antibiotic policy, and the system automatically tells you that if the first line has been qualified, that is sufficient for you, and it switches off the rest of the antibiotics. The technician does not have to understand, the lines. The technician does not have to understand, that he has to report an XDR or an MDR or a PDR, right? The system automatically does that. When it does that, it makes it easier. So the point I'm making is, even in an Indian setting where we are resource scarce, a simple technology-driven tool with a lot of intelligence, with a simple ability to put in basic information, enhances the quality of testing. We're hoping that such a thinking or such a system can improve the volume of testing, because anybody can test. So the thinking that I think we like to leave behind is, why can't we use technicians and why can't we use technicians and effectively use them to do the testing, which is what they do. But if they can use a simple system such as this that is made available easily anywhere, you can actually even have testing happening in remote locations. So that's one element of how you can do interpretation reporting. The second is about the quality of report that you generate. Now, by digitizing the technician who's actually doing the test does not have to think about what is he going to write. He does not have to do a cut and paste. The system uses AI to actually generate this text. System uses AI to arrive at a whole lot of piece of information and also uses signs. So so this becomes automatic. So which means even a low resource setting, you have better quality reporting. And clinicians can now get a 4-page report, which tells them not just which antibiotics they should use, but they also get a sense of, if I blow this up, they also get a sense of BMQ or therapeutic index. And they also understand, if there's a change in the antibiotic that was suggested before. So suddenly you have that better quality reporting process, which can happen. Nothing has really changed. All that has possibly happened is there is this digital capability which a technician will use. Now, having said that, there are huge benefits of doing this, right? When you look at, if not, so whatever I said was at the healthcare setting level, it's at the clinician level. But when you look at a state level, when you look at a national level, right? Also, there are benefits because now you can actually compare information across hospitals. You can look at by specialties. You can look at by time frame. You can look at what needs to be done, specifically in a healthcare setting. So the entire workflow suddenly will begin to happen. You don't have to send paperwork. Every single report that's been generated can be actioned. Information can be I think Dr. Sonal spoke about how the turnaround time to even make information available to the clinician can be significantly reduced. Obviously, this benefit offers a standardization of reports because you are now looking at similar kind of reports being accessed by clinicians. They understand it better. There's a higher quality of report, which means they're standardized in a certain manner. And this is possible by just creating that technology layer of digitization. Then you look at, because the data is now available, there are a whole lot of other things that are possible. Right? There's a continuous visibility of trends. Stewardship can play a role. You know what antibiotic has been suggested, what was prescribed. You can decide, should I take that antibiotic off? You can talk about de-escalation. And I think one of the speakers spoke about how de-escalation does not happen. And I think in many places, de-escalation does not even happen because we don't even have the information. We don't even know what's happening. We do not know how long has the antibiotic been there for. We do not know if another test was done. And with integration to hospital systems and taking digitization to another level, that's possible. So the decision-making capability, the ability to generate insights will significantly or drastically change. Then you quickly look at antibiograms. Now, typically today, I think with our experience working with 100 plus labs or 150 plus labs, we know for sure that antibiograms are not created more than once a year, possibly twice a year, right? It is often delayed. You cannot distribute the antibiogram to everybody. So how do you deal with that? Once it's digital, you have the ability to send either parts of that information or use that antibiogram effectively all the time. You also now have the ability to look at, because you have data, you can now stratify the antibiogram. Now, rather than just have a routine antibiogram, which just has a drug-bug combination and it appears something like this on the left-hand side. Now, with digitization, you will be in a position to look at the antibiogram with respect to the location of care, or was it hospital acquired or community acquired based on the specimen type. And we have some 15 different filters. So stratified in a manner in which the clinician can choose the right empirical antibiotic, and ensure that his therapy is accurate, it reduces risk of treatment failure, and that can be enhanced. We also have now launched a purified antibiogram, which basically means that, like I said, we possibly apply 100 plus rules and ensure that all the noise is cut off. So your antibiogram now is much clearer, truer, and hence can lead to better meaningful therapies. Now, obviously, when you apply AI or ML on that, there's a whole lot of other information available. And I believe we are working towards ensuring that we can now get into prediction. How do you look at using AI, ML to predict. Now, this AI ML will just not work if we just don't have the data. It can't be paper-based work. It has to be digital. And digitization will help not just doing getting predictive insights, but allow you to do all kinds of flags, allow you to look at it being absolutely personalized recommendation, and you can keep tailoring that and making it better. But how do you make the antibiogram available to clinicians, and how do you engage clinicians meaningfully? And we have seen that by enabling the entire antibiogram onto a treatment guideline platform. So we have an app, and we believe a mobile app is the easiest thing for us to engage people. And if you provide the ability where the clinician gets something for his benefit, he can access it. So you can either load it with ICMR treatment guidelines or the hospital's own treatment guidelines. But for the vast majority who do not have a microbiology lab, who do not have a microbiologist dealing with things, who do not have a department which deals with AMR, you may use an ICMR guideline or you may use a national guideline. And when the clinician is using the guideline, when he has the ability to kind of zoom through and find out what is antibiotic that he should use, it could make phenomenal amount of sense, because now then you're pushing the clinician to look up and understand what does he do for empirical therapy. And because it's digital, we are able to now look at some projects where we also provide clinicians the ability of understanding what are the daily drug dose, what are the days of therapy, what works in the hospital, if it's a hospital, what is the recommendation and how's the recommendation changing, right? And we believe engaging clinicians this way will allow them not just to look up and get onto prescribing the right empirical therapy, but it'll also allow them and engage them in pushing people and asking for or pushing for a diagnostic first approach. And we believe this would be required, because if the clinician is not going to ask for an investigation, it is not going to happen. But if a clinician can ask, it can happen. Finally, I think this is my closing slide. And I think while I would want to make a statement saying the digitization transforms the AMR problem, I would list the left-hand side as a problem that I started with. The issues that we have: resource constraints, we have limited microbiologists, we do not have enough testing that's happening, we do not have enough data that's happening because most of it is manual. If that is the problem, and as the previous couple of slides is a solution that we can evolve, I believe now you have the ability to look at better insights, better action, you have actionable solutions. And I believe this could be the digital solution that can, at least to some extent or to a large extent, solve the AMR problem. So with that, I think that's my last slide. And thank you so much, Coach, for giving us the opportunity.
Thank you, Dr. Bernard, for this very, very useful presentation, which will definitely have a lot of dialogue. What I'll do is, we have some questions for you, but we will skip that at this point of time, because we are, a little short of time at this point. And I will request Dr. Jaideep Chaudhary to kind of take to the next presentation from his experience of practicing in Kolkata with the pediatric population.
Thank you, Dr. Ghosh. Yeah. May I share my slide, please? Just a second.
Yes.
I believe my full screen is visible.
Yes, we can see it. Thank you. Not the full screen. You need to do the full screen.
Not the full screen. Okay.
Yeah. Now we have it.
Yeah, no. Okay, you had already. Okay. Just again, share again. Hope now it's okay. Yeah.
Yes.
So thank you. Good evening, everybody. It's a pleasure to be in this forum. Actually, over the past 1.5 hours, much has been discussed. I think all the aspects of antimicrobial resistance and how can we progress, everything has been discussed in a very nice way. I would like to start with few of the common situations that we often encounter, and that ultimately cascades to antimicrobial resistance. Few of the clinical conditions that often we encounter. A newborn baby who had no risk factors was well after birth, was kept in the nursery for observation for 48 hours. But it was an IVF baby, a precious child. So the baby was given cefotaxime and amikacin as it's a precious baby. What happened that comes a week later with sepsis due to ESBL producing Klebsiella pneumoniae. What was the error? Here the error was given antibiotic when it was not required. A precious baby is not an indication for antibiotic, but often in many of the neonatal intensive care units, especially with precious baby, antibiotics are given just like that. 2-year-old asymptomatic child, close contact with TB, was on INH prophylaxis, developed fever, cough, and weight loss, so rifampicin was added. Child not improved after 6 weeks. Then CT chest showed massive lymphadenopathy and gastric lavage, was Mycobacterium tuberculosis resistant to all first-line ATT. What was the error here? Actually, any child in contact with a confirmed TB should be investigated for active tuberculosis or not. If not, then only prophylaxis should be started. So here the error was giving inadequate number of antibiotics, and that led to the drug-resistant organism because the child was already suffering from TB. 1.5-year-old boy, fever, irritable, red bulging eardrum, diagnosis was acute otitis media, put on amoxicillin clavulanic acid on correct dose, but the parents reduced the dose to half as the child developed diarrhea with full dose. 4 days later, still febrile, had a convulsion. CSF was H. influenzae. What was the error here? Giving antibiotic in inadequate doses. So a clinician need to explain this to the parents. Preterm lethargic baby had convulsion on day 4. CSF was meningitis, cefotaxime, amikacin started. The child improved, looked fine in 9 days. And as the parent did not want to stay in the hospital, the baby was sent home on oral antibiotics. Comes back a month later with brain abscess due to ESBL E. coli. Here the error was giving antibiotic for too short a time. And these are not very rare situations that we deal on a day-to-day basis. So when we use antibiotics, one is the therapeutic use, used to treat an existing infection. One is the prophylactic, used to prevent. Now, when there are definite guidelines of prophylactic use that all the clinicians need to follow. In therapeutic, it may be a definitive, where proven pathogen with or without antibiotic susceptibility available, but still we can treat with some antibiotic as per protocol. But what happens is that most of the time, empirical antibiotic has to be used for therapeutic purposes. So it's a presumptive treatment. Bacterial infection probable but not proven, or bacterial infection most likely, but organism sensitivity is not known. And unfortunately, this empiric use of antibiotic is maximum, and often we are forced to do empiric use, and there the rationality should be there. What I would like to further point out, it's not only the clinicians who are the sole responsible. See, this type of combination like amoxicillin cloxacillin is available in the market, where amoxicillin is inactive against staph and clox, has hardly any effect in strepto. So for any given infection, one of the component is useless. And when it's combined, the amount of each drug is halved. So the efficacy reduced and chances of selecting resistant strains increased. But this is available in the market. Same, ciprofloxacin or ofloxacin with metronidazole or tinidazole or something. The mixed infections are very rare. And if it's a Shigella infection, cefixime is the drug of choice. Amoebic dysentery, rare. Stool test to be done, but again, there is metronidazole, tinidazole. So what's the indication of this combination? Why this combination is available in the market? Same, like the fluconazole, tinidazole, doxy, tinidazole and all. Then Cefixime and azithromycin, absolutely no use. Different pharmacokinetics. For typhoid, it's always the monotherapy. So this combination is again superfluous, and this is easily available in the market. And I have given just a few examples. There are so many. So prescribing practices in low middle income country, what it reflects, there are multiple studies conducted in diverse settings, which has highlighted inadequate knowledge and awareness regarding rational use of antibiotic. The knowledge and awareness is lacking, and I'm very sorry to say, even in the undergraduate or also postgraduate, there is hardly any emphasis on the rational use of antibiotic. And among physicians and medical students in resource limited setting, it's the same scene as I just told. And antibiotics are often prescribed by a wide variety of persons with diverse level of training. Not only the paramedics, but alternate systems who are not supposed to practice medicine, also chemist shops, faith healers, and also quacks, which are rampant even in cities, let alone in the villages. So all these contribute to this antimicrobial resistance. And if we see the antibiotic consumption between 2000 and 2015, the global consumption increased by 65%. And antibiotic consumption rate increased by 39%. So it's huge problem. And increase in global consumption was primarily driven by increased utilization in low middle income countries like India, China, Pakistan, these being the leading consumers among them. We have to introspect. Are we justified in using this particular antibiotic for this indication? In India, if we see, the largest consumer globally, second highest between 2010 and 2020, 47% increase. Private sector use increased up to 2016, then marginal decrease and wide disparities across state, and inappropriate use of broad spectrum antibiotic, and as I told, fixed dose combination used very commonly. So we have to watch for the AMR. The AMR concept was already discussed, but we have to watch. There are three, the AMR classification of antibiotics are three classes. One is access. That is community acquired susceptible pathogen, low resistance potential. Ideally, these antibiotics should be used more often. There are 48 enlisted, of which 19 are of WHO enlistment also. Then there is a watch category. For specific infection, higher resistance potential, key targets for antimicrobial sensitivity. So this is a category which should be nurtured and used cautiously. And the reserve, which should be always kept in reserve for suspected or confirmed NBR pathogens, and this should be the last resort. But if we see globally, this is the antibiotic consumption in children. You see India, where if you put the AMR classification here, the access group of antibiotics are comparatively smaller column compared to the watch group. And then there are the reserve group, and some are of course unclassified. Ideally, the access group should be the largest. Then there should be watch group and reserve group minimum. But this is the real scenario, and this is world over, as you can see here. In the pre-antibiotic era, the infections were life-threatening or not treatable. In the antibiotic era, the discovery of penicillin and later other antibiotic, the infection became treatable. So antibiotic was used irresponsibly because people thought that antibiotics can cure everything, even the viral infections. So resistance appeared and spread. And in the post-antibiotic era, it was the AMR, and that has escalated. So all the advances in medical science are on the verge of being nullified because the resistant infections are increasing by leaps and bounds. And AMR, one of the top 10 global threats in health. Now the leadership commitment, everybody in this depictions that depicted in the slide are important. The ID physician, the microbiologist, the information system specialist, ID clinical pharmacist, hospital epidemiologist, and infection control specialist all compose the AMS team, and they all are responsible. And the perfect coordination is ideal, but that is so difficult to achieve, and more so when it comes to the community level. So accountability is for everybody, and lot of actions can be taken, like the antibiotic policy, training, the antibiotic timeout, prospective feedback, tracking, and that process, the use measure, the outcome measure. You all are aware, but this is a very complex goal to achieve. What remains most important is the education of the doctors to think rationally before practicing antibiotics. So how to implement? It's a challenge, is all over, but we have to try until we succeed. And there has to be beginning, and each one has to make an effort, and that's the bottom line. So there are definite barriers, like the lack of awareness that we can find in the community level, in practically all level, even in the from the parents also. They go to the pharmacist and ask for antibiotics, and they get it easily. As we were discussing in the UK, not even the general practitioners are allowed to prescribe antibiotics, but here it's available everywhere. Limited funding, inadequate infrastructure, and shortage of trained personnel, that also creates another issue, because then we have to rely on the village people who are dependent on the other than qualified physicians for antibiotics. So it's the individual level, it's the nursing home level, and it's the hospital level. It's all cascading. And for achieving antimicrobial stewardship, again, what was discussed, the diagnostic stewardship is more important. Definitely AMR knowledge and the rational use also play a role. So how to improve antibiotic prescribing, the empiric use? Well, we have to be rational for empirical use. The clinic, one has to be clinically certain. The probable bacterial infection should be convincing enough. An atypical course of viral infection may often mimic a bacterial infection, and then prophylactic antibiotic. It's for specific pathogen and for susceptible host and for definite period of time. There also we have to follow the protocols. So again, for this empiric use, we have to be rational and we have to follow some protocols. Then there are some local guidelines. There are many local guidelines. Indian Academy of Pediatrics do have many local guidelines, but I'm definite, and I'm sure that not all the 40,000 members of IAP are aware of these guidelines, and hardly a minimum percentage might be following these guidelines. But there are guidelines. These guidelines have been discussed. These guidelines have been rolled out. These guidelines have been propagated. There are respiratory treatment of infection. GEM, there are PSPID, antibiotic prescription made easy guidelines, standard treatment guideline, but it hasn't percolated to each and every pediatrician. So there is lack of uptake, lack of awareness, lack of availability, lack of local adaptation. So many factors interplay. Antibiotic timeout, de-escalation, and IV to per oral therapy. This is a huge field that we could have discussed for a long time, but it has been discussed, touched upon. So antibiotic timeout is very important. Is it a bacterial infection? Can the spectrum be narrowed? So these are all very important. And I think I will just briefly touch upon this because this was discussed a bit. So we have to be rational. This was a child who had an abscess and cellulitis. The pus was drained. It showed gram-positive cocci. Initially, Clinda and Cloxa was added. Do we need to change? Well, we got a culture sensitivity report. It showed only as plus, but this is not rational. So these zone diameters, this lead to erroneous interpretation. So we need to look for the clinical breakpoints as sensitive, resistant, or intermediate. Based on that, we have to go for the antibiotics, whether it's sensitive, resistance, or intermediate. So this, according to this interpretation, if we extrapolate to the isolated organism, then penicillin and piperacillin are resistant, definitely. If we have to narrow further, we have to think that despite in vitro susceptibility, Cipro and ceftazidime are not preferred agent for staph. Clindamycin sensitivity need to be confirmed by D-test. Erythromycin is bacteriostatic. This is a pus, so we should not go for our bacteriostatic antibiotic, and Vanco and Tico should be reserved for MRSA. So we can narrow down further on this, and So the drug of choice here remains cloxacillin. Unfortunately, cloxacillin is widely not available all over India. But if it's available, it's a great drug for methicillin-sensitive Staph aureus. But this interpretation, this application is not there, and it's not uniform among the pediatricians, I'm sorry to say. And there are guidelines. ICMR has guidelines. It was a 2019 guideline, and it has the isolation rates of key pathogen was depicted in a table. And there's a guideline for developed by the Department of Health and Family Welfare, Government of West Bengal also. But these guidelines have limitation. Not only it has reached everybody, but if I say from pediatric point of view, there is hardly any focus on the pediatric patients. Same is the national treatment guideline for antibiotic use in infectious diseases. If we see the pediatric infections, there are very, very limited mention, and also it is not a very widely read, or not even what students we have faced in the medical colleges we often face, they are not aware of these guidelines at all. So these are the drawbacks that we have. So one step at a time approach, that's use evidence-based diagnostic criteria and treatment, follow some recommendation, use delayed prescribing practices or watchful waiting when appropriate, like mild acute otitis media, one can wait. And this can be achieved by training the clinician and explicit justification. So urgent and antibiotic is not a very urgent medicine. It's not a very emergency medicine, except severe sepsis, severe bacteremia, or a suspected meningitis. Antibiotics can wait. We must be judgmental and rational. So we have to be very cautious for improving our antibiotic prescription. Now, audit antibiotic prescriptions is also very important. It might be a self-auditing also. Is the choice appropriate? Where the diagnostic criteria met? Is the agent as per the recommendation? Is the dose and duration appropriate? This can be done by self-editing. We need not do anything special. So the measure of antibiotic prescribing, the use and outcome, one is the process measure, the justification note, then of course the aware process that we have discussed, and then the outcome measure, the adverse drug reaction, mortality, MDR, cost related to antibiotic use. This all has to be monitored and reported. But again, the reporting of outcome is also not uniform. As say, we get the sensitivity report from the microbiological lab, but definitely it's not the other way. The outcome and the sensitivity of the particular antibiotic use is never reported back to the microbiology lab. So there is never that to and fro exchange of knowledge. So a good prescriber must improve antibiotic prescription. This should be by clinicians' use and by the parents also. And one must follow the 5 Ds, the drug, dose, delivery, dosing interval, and duration. So that is very important. But at the end, it has to be the good user also, because not only the physician, even if the physicians prescribe the right antibiotic in the right dose, but often the user, the parents, they have some definite notions and they stop the antibiotic midway or reduce the dose. That also creates the problem. So there are barriers like clinicians' knowledge gaps, perceived pressure to see patients quickly, concerns about decreased patient satisfaction if I do not prescribe antibiotics, even for viral infection, and patients demanding antibiotics. There is an exam day after tomorrow. The child is running fever from today. Why don't you give an antibiotic? Because you are not sure if it's a bacterial or viral infection. You don't have a conclusive proof that it's a viral infection. So why take the chance? Why not an antibiotic? So these all are factors. So training options, CMEs, then the leaders also, then making statements, education and awareness that we have been discussing many a times, the increasing awareness, available the diagnostic optimally that we have discussed, the microbiologist improve antibiotic prescribing by following the 5 Ds, start with a justification note. If I'm prescribing an antibiotic, then better. In the left column, we write that why we are prescribing azithromycin. why we are prescribing amoxicillin. Azithromycin is not a drug for upper respiratory infection because azithromycin doesn't cover strepto or staph. That's usually the cause of upper respiratory infection. And then there is justification note and self-audit, as I was telling. So the baseline remains, we have to avoid antibiotic abuse. Thank you.
Thank you. Thank you, Jaydeep. That was fascinating. Brilliant presentation. Thank you so much.
Welcome, sir.
I'm sure that there are many questions, but unfortunately we are over time, so we will move forward. Now I will request Rajeshri Das to present on the PCI's work with the women leadership and how that can be translated into some of the AMR work that is being.
Thank you so much, Rajshankar sir. Good evening, colleagues and friends. So much have been spoken till now. And while we are ideating on smart diagnostics for AMR control in India, it is so very vital that this knowledge reach the community. And as we are talking about the smart approach, I would also like to draw your attention to one R, which stands for rapid. So the question is how swiftly we could reach the communities to raise awareness. Till now, all the experts have spoken about and ensure the community level stewardship. And based on our vast experience at PCI India on community engagement at scale, I would like to propose a 3L approach for rapid community level awareness and call for action on AMR control. The first L stands for leveraging the existing platforms, which has reach at scale, has last mile connect, and are also system driven. If I talk about schools, every panchayat and ward has at least a school. Colleges, every block has a college and has active NSS volunteers. Women collectives, every village has at least one women self-help group under the NRLM program. And these platforms could be easily leveraged to raise awareness on the risks which we have spoken about till now in the whole webinar discussion, the risk of antibiotic, for example, self-medication. Dr. Chaudhary just spoke, बच्चा का परसों एग्जाम है, give him or her antibiotic, incomplete courses, etc. The second L which I would like to propose is layering. These platforms, if are layered with key messages and also promote call for action through digital and non-digital products, and the focus could be on early diagnosis and timely referrals using very, very simple tools, these platforms might work very well. And I also feel that it will be an opportunity for translating science into story. I mean, till now, if we have heard, it looks like little complex science. But if it has to reach to the communities and communities should understand it, it has to be translated. The science has to be translated into story, specific, simple, action-oriented communication is the need of the hour. If we are talking about AMR control, some basic norms could be set up as part of layering on communication and educate every household through the existing platforms. And the third L, which I'm proposing, is leadership. And when it's about leadership, I would like to emphasize on the immense potential of women collectives and their federated structure, which is readily available under the National Rural Livelihood Mission. These women leaders could be groomed as champions and change makers on the AMR control issue. In past, these women collectives have demonstrated their potential by taking up various challenges. They contributed in improving the health and nutrition indicators in different states of the country like Bihar, Uttar Pradesh. They raised voice against the social issues like alcoholism, led the campaign against violence against women, delaying child marriage, etc. So, if they are capacitated, provided with simple tools, they have potential for raising awareness rapidly and with accountability and also inclusivity. And as Dr. Indrajit was sharing, women collectives are trusted platforms in the villages, and hence they could be leveraged for myth busting, relaying timely and correct information so that the households are empowered to be vigilant on the treatment they are receiving. I would also like to visualize all of you to visualize. Imagine like 1 million ashas in the country, 10 million women self-help group leaders under the NRLM program, and 1.4 million, this is the average number of Anganwadi workers. If they all collaborate, this huge force could reach to every household and has potential to strengthen the community-based surveillance and also stewardship. With this potential of existing platforms and cadres, both health and non-health, I would like to thank you all for listening and will be happy to take up questions.
Thank you. I'm sure that there are questions, but we will move on given the time. And may I now request Dr. Arista Lahiri from IIT Kharagpur for a conversation on enabling antimicrobial stewardship at individual, family, and community level through awareness and social mobilization, please.
Yeah. Thank you, Dr. Ghosh, and thank you. It's been, really engaging and encouraging and mind-blowing, as I must say. But okay, so as we're discussing on this topic, I believe most of the issues regarding AMR, its origin and how AMR spreads, all of these issues have been taken care of. So I'll mostly focus on how we as a team in IIT Kharagpur and with our collaborators, we are dealing with AMR at the community level and some of our key initiatives. So next slide, please. So again, these all issues have been discussed that yes, there is a burden, but one key point that I want to highlight is that the issue of One Health. This is one aspect that our team are working on, is the One Health aspect to address the issue of AMR at the community level. See, we do have the One Health committees and all the One Health experts working with AMR. But again, the problem remains that the AMR issue is mostly addressed at a clinical, typically a hospital setting or a lab setting. Now, what we are trying to do is we are trying to take this One Health concept and AMR to the community level. Next slide, please. Yeah, so as we have been discussing, there are certain gaps, most of the gaps at the user end, because we are focusing on the user end primarily. So at the user end, it's related to how antibiotics are used and how the users, they are taking the antibiotics. The issue that was mentioned that course completion is a necessity. Then again, these issues do come up when we go for field surveys and field studies. And in fact, we found out that there are national action plans on AMR, but we do lack a certain community-based prospect on how One Health can be utilized for mitigation of AMR. So that is why we proposed a theory-based behavioral framework that will be coming later on as an effective method of promoting appropriate antibiotic consumption and also antibiotic seeking behavior. Now, next slide, please. So the unique challenges we have been discussing regarding these concepts, again, the antibiotic resistance, the consumption rate, the over-the-counter sales, misuse, everything. But again, I would like to focus on the issue that the insufficient integration of the different sectors that is there, because we are working primarily with the One Health concept. So we focus on the integration component between the sectors who are, related to AMR control, and also the data that is there with the concept of AMR and One Health. The bridge between One Health concept of AMR, it requires certain evidences. So that is lacking also. Next slide, please. Next. Yes, so the community engagement framework and the social mobilization framework, this is what we follow, and this is precisely what Rajeshri previously has mentioned, that yeah, we have to inform, then we have to get some feedback. The essential idea or the core part is to involve the people, then build up certain partnerships, maybe with the organizations that are working with the community, and most importantly with the community itself. And in the end, we need to empower the community. So that is what our team, we are doing precisely. We are trying to empower the community. We are calling it as antibiotic literacy. In certain spaces, we are also calling it an antibiotic resistance literacy, because we are mostly working with antibiotics. And we feel at the grassroots level work that once the community members, they are aware about this concept of antibiotic, the broader concept of antimicrobial resistance, it's become easy for them to understand. Next slide, please. Now, so this is the core area where we work. We work with the One Health concept. Now, as you can understand, the One Health concept, it integrates these 4 different domains, although in some instances we try to, integrate animal and food and agriculture in the same domain as veterinary and agriculture, but we tend to keep it separated. Next. And next. So the previous one. Yeah, so the issue was just the findings that we got from our community level study that we conducted in West Bengal. One of the sites was a tribal dominated area, and the other site was a severely urbanized and, the overcrowded regions, as we usually know. The common factors that we identified were mostly improper antibiotic consumption as well as disposal practices. Now, I mentioned disposal practices because we also tested certain environmental, residues and everything. And we found out that these improper disposal practices, they lead to the development of antibiotic resistance in the community itself. There is the lack of infection prevention practice, and it is not only in terms of the human beings, although the practice is from the human aspect, but not only for human, preventive practices, but also for those who are handling animals and also who are engaged in food and agriculture. So the infection prevention practices, it really needs to be taken care of. That is one of the findings that we got. And obviously in veterinary sector also, we found out that there are improper antibiotic usage practices. So it relates that it's not only the human beings who are at threat of antibiotic resistance, the animals are also having a threat of antibiotic resistance. And in a way, as we have seen with the COVID-19 virus and all the other zoonoses and everything, we are forced to call that AMR has a zoonotic potential and a severe one. Next slide, please. Again, as the time is short, I'm not going into details of these different initiatives that we have taken from our group. These are just outlines of different action points that we are implementing as part of our different studies. Some of these studies we have completed and some are still ongoing. So as Rajesh has mentioned, the schools and the youths and the community members, the active ones, if you engage them, you can get a better result in building awareness and engaging the community. So we did a multi-modal kind of intervention where we engage the schools and the youth. We built AMR champions, and also we developed peer networks. Now the peer network one we are particularly looking into now, as well as we have done in our previous ICMR funded studies. The findings we were discussing in the previous slide. Also, the use of technology, now digital tools. I will not again go into details of digital tools because we have been discussing with the digital tools over and over again. But what I'll focus is we are working on digital tools that are focusing, typically at the community level, something for the community members to work on, not only for the hospitals or, the doctors only, something for the community members to maybe make themselves aware, maybe to have some, ready to use guidelines on when to use, when to go to a doctor and when to ask for antibiotics, because this is a very common practice in this region that people, they go to a doctor and they usually ask, doctor, please prescribe us antibiotics. So again, this leads us to a market-driven question, because if the patient is itself asking the doctor, the prescriber, that we have to give an antibiotic, and again, if the doctor is not prescribing antibiotic, the patient is going to another doctor, and if eventually the patient is finding a doctor who is giving the antibiotic, and then that particular doctor is retaining these kind of patients. So again, it's not only about the prescribers, it's also about the users. You have to make the users aware that it's not always that if you are provided with antibiotics, that is only not the beneficial part. No, antibiotics alone are not the beneficial ones. So this is the part that we are focusing on, because as we have been discussing, most of the illnesses that are there, most of them, they might not even require antibiotic, but we have to make the community members aware of that. This is the typical part where our peer network comes in handy. And finally, the engagement through folk and traditional media. See, this is the intervention that we're working on now, because the tribal community members with whom we're basically collaborating, and we're empowering them also. We are coming up with this traditional and folk solutions where the community members can relate to the solutions that we are talking about, or even they can relate to the materials that we're providing them, because often the IC materials that are usually used in the field, they are tested, but the community members who are far from the urban regions, they might find distant from the IC material. So this is the part what we are trying to take care of through the folk and traditional media component. Next slide, please. Yeah, so some important findings in the previous slide, the One Health one, we presented basically the findings where the key bottlenecks or the key problem statements. Now, in this slide, what we're trying to focus on is how community engagement and empowering the community members, they improved the situations. As you can see, we have highlighted that the community engagement and the empowerment of the community as a whole through peer networks and all, they improved their appropriate antibiotic consumption practices in a way that reduced the people's behavior and going to a doctor and seeking for antibiotics actively. So there were some participatory and non-participatory observations. I'm not going into detailed methodology, but it evidently showed that the antibiotic seeking practices were turning to a more appropriate level. Also, because we developed a behavioral construct focused intervention, implementation of this particular behavioral construct focused intervention, it improved their behavior, and thereby ultimately the subsample of this huge population where we conducted this study, it showed that the AMR burden in human samples, it decreased, because obviously for funding reasons we did not test the veterinary samples, but we're kind of certain that if a similar kind of finding is evident in human samples, the veterinary samples will also show that the AMR level has reduced quite a bit. Next slide, please. Next one. Yeah. So again, there are certain key barriers that I actually wanted to talk during this presentation. So the major part is the limited access to the trained providers. So as we were discussing, the informal healthcare providers, they are also prescribing antibiotics, although we can limit them by law that you are not allowed to prescribe antibiotics, and you should not. But again, as I have said, that it is up to the consumers as well. They will go to another person who will ultimately prescribe the antibiotics. So this is kind of it's a very intricate issue where we see that the community members become vigilant and aware, and this can only be done through intense community engagement. And there is one interesting finding. I think all of you can relate to this finding, those who are in clinical practice and those who are in field-based public health practice as well. There is a gender differential to AMR as well. As we often see that in different diseases, typically in rural, tribal, and these kind of marginalized areas, the females, they are typically, as the term says, neglected. They do not report to the clinics, they do not report to the doctors with their problems and everything. And a similar differential we found out with the females as well. There were instances where the females who were prescribed antibiotics, the head of the household, they said that you don't have to take the whole antibiotic, because the part of the antibiotic course that is left over, that can be used for the another person. So there are a lot of issues. There might be certain issues that involve economic considerations as well. But overall, the issue here is the gender differential, where the females are typically neglected. But through this neglect itself, the antibiotic resistance, it is spreading within the community. So again, this is another area that community engagement and true community awareness can improve. Next slide, please. So as we were discussing that we need to empower the communities, we need to go for further tailored management. Firstly, we need to make the community members aware that antibiotics are not the solution for everything. And it's not like that the doctor who gives you an injection or gives you an antibiotic that is the only solution for the treatment or the problem. So this part we need to take care of. We need to promote for a cross-sectoral interdisciplinary collaboration for coming up with AMR solutions. There are digital health practices, there are typically community-based practices, but we need to find certain working solutions, and then we can integrate them together to build a more effective one. Next one. Yes, so to finish off, as we were discussing for more than 2 hours now, AMR is a problem. And what I would like to propose and what I would like to emphasize on behalf of my team as well, that we need to break the silos. We need to focus more on this One Health concept, that it is not only a human problem. The problem is there among the animal sector. It is there among the practitioners with the environmental health and also in the agriculture sector. So we need to come together and we need to build a solution that promotes community awareness and also empowers the community. Yes, so that's it from my side.
Thank you.
Thank you very much, Dr.
Thank
Ghosh.
you. Thank you, Dr. Laidi, for this emphasis on an integrated approach in terms of our healthcare delivery. Given that, we are running much short of time, I will just request Professor Dheer to talk about the next steps. And with that, we will close the conversation today. Professor Dheer, please.
Right. Yes, thank you. Thank you so much. I think my colleagues, it has been a wonderful dialogue for the past 2.5 years. I hope my screen is visible and I'm audible.
Both.
But yeah. And I think for the past 2.5 hours, listening very calmly to all the experts, thank you so much for this particular dialogue. I think one truth actually stands out, that we must actually move from science to stewardship. And let me try to frame this summary and try to integrate what we have actually learned. I just have 4 slides. I'll take less than 2 minutes to actually summarize this. In the 5S framework, that probably has come out very well when all the speakers were actually talking about. Where the first 2S stands for the speed and the systems. And I was glad that Dr. Sonal, when she reminded us that probably the time is the treatment, is something that probably she had mentioned, because early infection detection actually enables very targeted treatment. And this also helps us to come forward with the solutions that reduce unnecessary antibiotic prescriptions. So thank you so much, Dr. Sonal, for that. And also probably Dr. Bernard view on the systems, the data, and this is where probably IIT Delhi always gets very excited regarding the live dashboards. And there was a question by Dr. Amrita also, that how do you take it from the field to the lab where we can actually see this? And I think this is where probably Dr. Bernard showed us that there can be and there was a digitizing microbiology across 100 hospitals, created dashboards that guides the doctor instantaneously. And that is one thing that IIT Delhi has been working along with the different partners, of course, with the PCI, to actually bring this data and the analytics into the table so that we can actually analyze that very nicely. So the first 2 S, the speed and the systems, was quite covered. And the next 3 S were the scalability, society, and the synergy. And this is where Dr. Nikhil was very clear in terms of when he was talking about that gone are the days when you need to copy the foreign nationals. I mean, we have a very customized country. We have a very customized, context of India. And this is where probably, one size won't fit all. Dr. Inderjeet also mentioned in his initial step that probably we need to have a very customized strategy for making sure that this is scalable, also affordable, because society comes forth. And Dr. Rashri, and thank you, Dr. Arista, just for touching upon the community angle, because this is where stewardship begins at home and in the communities. And this is what the behavior change, the collective action among the states, hospital labs, innovators, communities. And this is where the teamwork comes into picture. And that is why probably we have collaborated with PCI as well as the other partners in this particular meeting to actually come up with some of the shared learnings. And this is what we are going to do. We are going to integrate the S.M.A.R.T principles as well as this 5S principle as next step. We'll try to document it. That has been our strength, to actually come up with a very systematic document where we'll try to capture these rich discussions that has actually happened, circulated among the speakers, and of course that will be available to the larger public. But I'm sure that this is going to be a series of dialogues, and we'll take it step by step forward our learnings, our discussions, and this dialogue has to be open to actually help us to come to a common understanding of what we understand from this, because this is in the design thinking of strategic management, we call this as a wicked problem. And this wicked problem can only be solved when the different stakeholders from different fields come together, brainstorm, and then probably come up with a systems view, a holistic view in terms of how we are going to solve this. So thank you so much. I think I'll end here in the paucity of the time, but it has been a great collaboration. Thank you. Thank you so much for this, great
Thank
2.5
you,
hours.
Professor Dheer. Thank you, as always, very crisp and very, very targeted kind of message. Thank you, everyone. So I think we have questions, but we will not take the questions now. If there are specific questions, we would encourage the participants to send us the questions. We will send it to the various presenters and we'll get back to you. On behalf of the PCI India team and the QEI initiative, I have real pleasure and honor to thank all of you, the speakers, and also the audience, and those particularly who asked the questions. Thank you so much for your patience and for participating in this conversation today. The journey has just begun, and as Indrajit said, that we will take this forward towards some implementation demonstration, and with support from you and with collaborations that we can take forward. Thank you so much, everyone. Have a wonderful evening. Thank you.